I teach on quite a few burns and plastic surgery courses. I'm sure you all do the same. And this is one of the questions I always ask, and I'm sure you all know the answer to this. What does the word debridement mean? Yeah, you all know what it means. Getting rid of this stuff, yeah. And this is something you will find in all the textbooks. What are the methods of debridement? And I'm sure you can all list various methods of debridement. And that's the kind of list you'll see, and you'll see that in any textbook. And, you know, I'm a surgeon, so when we're giving lectures on how to debride, you start with the top ones, and you sort of lose interest as you go down, you know. Because the important stuff is at the top, you know, the surgical stuff. So, knife and scissors, yeah, we're all used to that. VersaJet, quite a new, well, that's the last thing, the last tool, I think, for debriding agent that came along. When was that? In the 90s, late 90s, the VersaJet came along. Mechanical, what does that mean? Mechanical debridement. You sort of give it a rub, your debris softs and all that kind of thing. Yeah. Autolytic, what does that mean?
No.
Yeah, that's right. So you're saying, if I leave it to be moist, maybe some of your own tissue will eat it up. You know. Biological. What's that? Larvae. Yeah, I like that larvae. Except you could probably say biological was enzymatic, couldn't you? Because that's how it works, isn't it? They spit into the wound with their enzymes, and then they suck it up. It's not like they've got teeth and go, Other enzymatic? Collagenase, Nexabrid. So, not commonly used. And then chemical, I used to gloss over that one. Now, we don't have to gloss over it. We've got a chemical debriding agent. Guess what? It's cold. So we want to be speedy. We're very impatient people. And we want to do everything as fast as possible. So tough tissue, for me, the knife is the quickest. So that muscle or fat, I find that if you use a knife, it kind of bounces away. Whereas you can grip it with the scissors. You grip the fat, and then you can cut. But then there's this loose tissue that's hard to pick up. Because what we like to do as surgeons, or as nurses, is with our left hand, we grab the tissue, we pull it as tight as we can, and then with the right hand, we cut with the scissors or the knife. But there's some tissue that's hard to pick up, you know, doesn't want to pick up. That's where either the VersaJet is very good, or the DEBRICHEM will deal with it. So as you can see, it comes in a huge big red bottle, like that, the actual size of the bottle. You dip the patient into the bottle. But so you put it on for a short period of time. You're putting it on for 60 seconds. And it is a very strong acid. Any of you who remember your chemistry from school, it's got a negative pKa. It's not really an acid until it is in water. But it's not in water yet. It's not in water when it's in that bottle. It's only touches water when you put it on the wound. And the biofilm is mostly water. So it's going to suck out all the water from the wound. It is painful to do that if it's a sensate foot. Some of your patients are insensate. But patients who are not insensate, you will need to anesthetize them. So, for example, putting on EMLA cream, okay, for 10 minutes. So that's a change to your practice, I admit. You know, some people don't use EMLA routinely. So you will have to work, if this is new to you, it will require you changing your practice slightly. And a lot of people don't like any change. That's not the way we do it. Particularly as you get older, like me, you become more resistant to change and more, this is the way I always do it. So try and avoid that. But some of your nurses might, this is newfangled technique. You can, whatever you want, whatever is legal in your country. In the UK, EMLA is the only cream that is licensed for open wounds. But that might vary in different countries, I don't know. You have lidocaine spray, even better. So, now, the problem with infection is, what I call infection, you might not call infection, we would all give a different opinion, because we would all see things differently. The ones on the left-hand side, overt signs of infection, are easy. I think most people, if you see a wound with these features, you would say, there is bacteria at the root of this problem. But on the right-hand side, it's a bit less clear. That friable granulation tissue, maybe increasing odor, increasing exudates, that kind of thing. There are more subtle signs. So we just got a nice glossy video here showing how it's put on. So you want to put, if possible, you want to be putting it so that the wound is uppermost. Because obviously if the wound is on its side and you're trying to pour on a liquid, it's going to run off. So if you can, orientate the patient so that it is uppermost. Dry it, give it a clean. Yeah. Then you're going to put the EMLA on, and then you're going to put on the DEBRICHEM. And it's like a red, oily liquid. And to me, it smells of beetroot. They assure me that there's no beetroot included in the recipe, but I'm not sure I believe them. So here we go. This is the EMLA being put on, or whatever you want to put on or you could put an injection. You could inject local around it. And there it is. You shake it, it makes it a little bit more liquid, a bit like ketchup. Shake it. You've got to use gloves and make sure that you've got eye protection. So either wear your own glasses or put on a pair of goggles and then put it on, and remembering to put it into not just the wound but the peri-wound. For those, I don't know if any of you use the moleculite, but if you use the moleculite, you'll be aware the bacteria, they love hiding in the intact skin. And if you don't get rid of those, they'll just jump back in. So we're putting it on, and we're leaving it on for 60 seconds. And during that time, you'll see the color change as the sugars in the polysaccharides in the bacteria and the biofilm get turned into carbon. So we did a service evaluation last year, 21 consecutive patients. The usual comorbidities you get with leg ulcers. So a lot of DVTs and obesity and all that, and rheumatoid, etc. BMI of 32, which is normal for the UK, I'm afraid. And they'd all had wounds for quite a long time. And none of them had shown any sign of getting smaller for at least 2 weeks. A lot of them a lot longer than that. And they all showed some of those signs of infection, those overt and covert signs that we talked about. And here's one of my nurses. Just to reiterate how you put it on. You've got to wear the PPE, obviously. Any questions so far? No? So it's taken off the, obviously you've got to take off the old dressing and give it a clean. And you can see the exudate there. And you can see from the color of that exudate that there's been some neutrophilic action going on. Now it's a bit difficult here because of the position of it, but try and get them to put the leg in a little bit more upright. So she's putting on the EMLA. How long? 10 minutes. Yeah. So what? Yeah. But that's for intact skin. If it's open, it's quicker. Yeah. But a half an hour won't do any harm. So if you have got another clinic room that you can go to another patient, and then you see it's gone on there, make sure you get the peri-wound skin. And watch the color change. Can you see it going a kind of brown color? And basically all the bacteria in that wound are now dead. So essentially you have a sterile wound with a scab, a sterile scab on top.
We removed the biofilm now, but it's so easy to...
It is. Come back. But that scab will act, as a mechanical barrier. And yeah, you could say, well, it will come back. Yeah, of course it will come back. That doesn't mean that you shouldn't address the problem that's stopping the wound healing at that particular stage. So we looked at things like what happened to the granulation tissue. So the green is the granulation tissue, and the granulation tissue increased, as you would expect, and the slough decreased. And that you can see that more graphically there, how the granulation tissue increases and the slough decreases. And these wounds that had been static now started to get smaller. So it's like the bacteria were really the problem for holding these wounds back. And look at this, this is the rate of change of the wounds, sort of the rate of acceleration, really. And you can see it's maximum in about the 2-3 week, and then it starts to go back to become less. So that's when you get the maximum amount of healing. And that might be due to bacteria growing back in, I don't know. You can see the exudate didn't really change very much. What was interesting to me was the pain, because some of these patients were very painful before they had the DEBRICHEM. And when I first heard about it, I was thinking, oh, it's going to be hard for these pain. But actually, you can see that there are some patients who had baseline pain before you did anything, and then now they haven't. Week 4, they haven't. And I remember one chap in particular, he was taking a lot of opiate analgesia because of the pain in his foot, in the wound. And the next time I saw him, he said, I'm a changed man. I don't have to take any of this analgesia anymore. So I don't know whether it's like bacteria causing the pain or whatever. I don't know why that is. So that's anecdotal. But you can see that's captured there in these patients. The pain is less. You can see during cleaning, the pain goes up, but it's still less than 3. And then during the application of the DEBRICHEM, the pain score is still less than 4 out of 10, so it's not too bad. Both the patients and the clinician, they liked it. So then I'm just going to end with some cases now. So a 62-year-old man, this wound completely static for 3 years and heavily colonized, and he was very reluctant to have any kind of debridement. We like to debride our wounds every time with a curette, but he wouldn't let the nurses do it. It's too sore. So, this is him here, yeah. So, yeah, that's the picture of the wound there. So what would you do there if that was your patient? How would you set about debriding that, what would you do? He doesn't want you to touch it. It's too sore. What would you do? Do you think there's bacteria there? I think so. That sort of golden crustiness looks very staphylococcal to me. So that's with the single application of DEBRICHEM. Single application, yeah? And you can see instantly he's now got this eschar. And then gradually the eschar will lift and come off. You see over the next couple of weeks. And now we're at a stage where this is now much more ready for healing. It isn't that disaster that you've got in the top left-hand side. And it's on its way to healing. And so that's 6 weeks there. You know, this is a patient that had this for completely static for 3 years. This was a 50-year-old, he was a drug addict. And he'd had DVTs and he was on some kind of blood thinner. So every time you debrided him, he would bleed. So nobody wanted to do a curette debridement. So you don't bleed with DEBRICHEM because it cauterizes. And then you can see it's gone on to completely heal. Likewise, look at this angry wounds here. Quite deep but difficult to get into the crevices. And yet, so we've burnt it now with the DEBRICHEM and then allowing it to go on to heal. And look at the picture on the left and then the right. Okay. That wound on the left, can you see how red and angry? You can feel how painful that one is. But look at it now, it's completely settled down. And I think that is due to the number of bacteria being less, much less. Yep, all of them with EWMA and DEBRICHEM. And then that's gone on to nearly heal. Now, as a surgeon, I could easily scrape this out, and it would take me 5 minutes. But this takes 60 seconds to do. My time is expensive. We're getting there. So now, there's certain things that are just quicker to do with DEBRICHEM than it would be for a surgeon, and this is one of them. Again, someone with we were wondering, is it you see the purplish tint? Is this a pyoderma? You know, when you debride pyoderma granulosum, you make the wound worse if you do sharp debridement. But in this case, we got it to get smaller. So this is a new tool for your toolbox. Doesn't mean to say that you have to use the same tool for every patient. But I think if you don't have this tool in your toolbox, you're not really doing your patients a service. Imagine if you go to you take your car to a garage and they say, well, we've got some of the tools, we haven't got all the tools. Do you want to go to that garage, or do you want to go to the garage that's got all the tools? And you're not going to use this on every patient, but there will be a significant number of patients in you that you see that will benefit from this. So, are there any questions? go. Thank you very much. Thank you for your attention.